Welcome, everybody. I'm delighted to introduce our speaker for today. That would be Dr. Kaila Stipancic. She's a licensed speech-language pathologist and postdoctoral researcher at the University of Buffalo in the UB Motor Speech Disorders Lab. She received her bachelor's degree in speech and language sciences at Brock University in Ontario, Canada. Her master's in communicative disorders and sciences at the University of Buffalo, and her PhD right here in the greater Boston area in rehabilitation science at the MGH Institute of Health Professions. She completed her clinical fellowship in speech language pathology at the University of Wisconsin-Madison, which is my alma mater, in an acute care setting. Broadly, she's interested in how the brain controls the muscles of speech and swallowing, and the perceptual, acoustic, kinematic, and neurophysiologic consequences of neurodegenerative disease on these functions. She has particular interest in the measurement of these relevant clinical outcomes, such as speech intelligibility, and in improving therapeutic options to improve the quality of life of people with oromotor impairments. In her free time, Kaila enjoys hanging out with her cat Mozart and traveling to see family and friends all over North America. We may see Mozart during this talk, and so we welcome both Kaila and Mozart to our community group tonight.
Thanks, Jen. Thank you so much for that great introduction. I'm just going to move us out of the way here. Thank you so much, all of you, for being here, and thank you. Sorry for having me. I'm really pleased to be here. Jen, that was such a nice introduction. And I probably will talk a little bit about some of those things in here too. I know there were a lot of big terms in there. And I'm going to talk about some of those today. I called this talk Measuring Speech and Intelligibility in ALS, but I also really want to talk about whatever you guys want to talk about. So please feel free to ask questions. I would love to make this as relevant as possible to what you're interested in. So feel free to stop me as well. Jen just talked about this, so I won't go through it very much, but I am from Southern Ontario. I moved over the border to Buffalo, made my way around a little bit, and now I'm back in Buffalo, which is very nice. But I wanted to talk about this just to give you an idea that while I'm a researcher and right now that's kind of my primary focus, I started as a clinician and did my clinical training and worked in an acute care setting in the hospital in Madison, Wisconsin. And so I am very interested in how we can help patients with our research. And that's really important to me, is having a clinical focus to my research. And this month is Better Speech and Hearing Month, or Hearing and Speech Month. And so I'm starting this off, I think, for you guys. And I like this theme called Building Connections, because building connections is all about being able to communicate with other people, I think. And that's something that I'm really passionate about, is helping people to better communicate with those in their lives. And I think communication is a big piece of building these connections. So Jen kind of mentioned my research interests, but just to give you a little bit more of an idea, I'm interested in how the brain controls the muscles that we use for speech and swallowing. And we call these bulbar muscles. So I might use that term a few times throughout this talk. And I'm interested in how this is affected by diseases such as ALS and Parkinson's disease. My work during my PhD was primarily in ALS. And now in my postdoctoral fellowship, I'm looking more at Parkinson's disease. And then I'm interested in how we can measure this. And so that's what I'm going to spend a lot of time talking about today. And then how we treat these impairments. So today I'm going to talk about how the brain controls these muscles, how speech is affected by ALS, how we measure it, how we treat it, and then save lots of time for questions and comments. I'm really going to spend a lot of time on measurement of speech because I think this is the most interesting piece, and I hope that you'll agree. So what do I mean by speech? I think this is an area that we don't think a lot about because we just talk and we don't think about how we talk. And so when we use the term speech, it's really important that we're all thinking about the same thing. So let's talk about how we use speech. First, we have an idea. This is kind of the cognitive domain. So of course I've used a cat here. We're thinking, oh, I want to talk about my cat. And then we put that into language. So we pick the word out of our brain and we say, okay, the word that I want to say is cat. And then we need to plan that. So planning involves thinking about how we need to move our muscles and our articulators, or our lips and our tongue and our jaw, to be able to say what we want to say. And so we're thinking, I need to say a k, I need to say a, and I need to say a t. And then we have to actually execute that. So this is when the word cat comes out of our mouths. And this is the area I'm really focusing on, is this area of speech motor execution is what we call it. And so there's several areas that we can look at, and we'll talk a little bit about each of these, but we're thinking about what does the word cat look like when it comes out of our mouths? What do the sound waves look like? And then also, what do the lips and tongue and jaw look like when that's happening? So that's what I mean when I'm talking about speech. And I really want to make it distinct from communication. So communication, I've used this picture here of these two brains talking to each other, because communication is really more, how does one person, one brain, get information to another brain? That can be any number of ways. There are a lot of ways to get a message across to people. But when I talk about speech, I'm talking about what's coming out of your mouth and going into the other person's ear, perhaps. So I think it's really important that we make this distinction. A lot of times professionals use them to mean the same thing when they don't actually mean the same thing to speech pathologists, for example. So speech is one of the most complex motor acts that we perform during the day. So we use approximately 70 muscles, which is always surprising to me. I always am surprised to remember how many muscles go into speech. And we use 4 subsystems. So the first is the respiratory subsystem. So we use our lungs and our diaphragm to be able to make air come up through our airway. We have what we call the phonatory system. So that's our larynx, which houses our vocal cords, or vocal folds, like we would call them. We have what we call the resonatory subsystem, and that's your nasal passage and your what we call the velum, and it closes off the nasal passage during speech. And so if you make a humming sound, for example, you can feel some vibration in your nose, and that's air coming out of your nose. And that's part of the resonatory subsystem. And then the articulatory subsystem is our lips, our jaw, our tongue, that we use to make speech sounds. So we need to coordinate a lot of different things to be able to produce speech. And speech has been described as this unique motor act because it relies on all of these other things. Like I talked about previously, we need that cognitive piece and the language piece before we can execute speech. If we don't know what we want to say, then motor execution doesn't really matter because we don't need anything to come out. And there's also a relationship between the speaker and the listener. So it's not just about what the speaker is doing, it's also that there is a listener there who needs to be able to understand what the person is saying. And speech also includes things like prosody. So we might think about this as emphasis. So if I want to change the way I'm saying something to make it a point, I might use different stress patterns. So I might say, my cat is over there, not over here, for example. And I might change the rate. So you can slow down how fast you're talking, or you can speed up depending on the situation that you're in. And also we think about naturalness. So how natural does our speech sound? Does it sound effortful? Does it sound like it's just coming out like you would expect it to? So we think about all of these things when we think about speech. Speech is a relatively young area of research. And so I just actually looked this up today. So what you can see here is some search terms that I searched on the internet, and I searched hand and grasp, and I got 33,000 hits. So 33,000 responses came up. But then when you search tongue and speech, you only get almost 4,000 hits. This is on a website that we use for research. It's looking at all the research that's available. And so only about 10% of what hand and grasp gets, tongue and speech also gets. So it's very early on in its development still. And so we really, the state of our science is really lacking, and we need a lot more research. But in recent years, we've also made a lot of progress, which is exciting. So you might be asking, why do we have such few studies? Speech is really difficult to measure, and I think you'll see as we go on why it's so difficult. But a few reasons why is because it's produced very, very rapidly, up to 12 sounds per second. So how do we measure sounds? How do we measure movement? Those are a lot of questions that we grapple with. Speech movements are really small and subtle. So think about moving an arm and how you can measure that. You can measure how much an arm is moving, right? And so it can be moving X number of inches. But when we're talking about, say, lip or tongue movement, we're talking about millimeters. So they're very, very small, which makes them more difficult to measure. There's, like I said, many muscles involved, and it's hard to disentangle them. It's hard to tell which muscles are doing what and when, because they all work together. And also parts of the speech system are inside the body. So when we're talking about the tongue, how do we measure tongue movement when we can't always see it? Or the phonatory subsystem. So how do we measure what the vocal cords are doing? Those are all areas of challenge for the field of speech science. And one other reason is because we're also interested in what the brain is doing, right? So not only do we have this very complex system over here that we have to think about, but then we're also thinking about what the brain is doing and how the brain is able to make all of this happen. And then we're also concerned about this. This is what we call the International Classification of Disability in Health, and it was produced by the World Health Organization. And it's a way we think about how we treat patients, the kind of research that we do. And to kind of break this down a little bit, we think about the health condition up here. So for our purposes today would be ALS. Then we think about what body functions and structures we're interested in. And so in our cases, we're interested in the sound waves that are coming out. We're thinking about the strength of the articulator, so the strength of the tongue, the strength of the lips. We'll talk about all of these in a little bit more detail in a few minutes. But just to give you an idea, we're also interested in activities. And so for this, we're interested in what we call intelligibility. So how understandable is a speaker to a listener? And then the last thing is participation. So how is that person participating in everyday life? And so it would be easy, or easier for us to just say, oh, we're only interested in body functions and structures. Let's treat the strength of the articulators. But that's not enough, because these are not directly correlated with each other. Just because we change something in one of these domains doesn't mean we change it in all of the other ones. So just because we increase strength, that might not mean that we change how someone is participating in their everyday life. And so there's a lot of things that we think about in speech research. We're also thinking about environmental factors. So who is the person communicating with? What is their profession? How much do they have to speak? And then personal factors like age, gender, motivation is a really big one, particularly for therapy. So a lot of things to consider. All right, so let's switch gears a little bit and we'll talk about how the brain controls speech. I'm just showing this figure just to show you that there are a lot of brain regions that are involved. So these are each a picture of a part of the brain. We're looking kind of at the side of the brain in each of these. And the red and yellow are the areas of the brain that light up when someone is producing speech. And so there's a lot of brain areas that are involved in producing speech, which makes it more complicated. These are what we call the upper motor neurons. You might hear that from a neurologist when you're in the clinic. It's what the brain is doing. That's kind of what we're talking about there. And then we have a lot of cranial nerves that supply the muscles that we're interested in. This is a pretty complicated figure, but what I just want to show you here is that this is the bottom of the brain. So it's like as if we're looking up at the brain. And these are all the nerves that come off that bottom of the brain and supply all of the different muscles of the face. So we have eye muscles, we have jaw muscles, we have tongue muscles. but there are a lot of nerves that we're thinking about. And these are what we call our lower motor neurons. So you might have heard that term as well. So those are the muscles that are coming from the brain and go into the muscles that we're interested in. And then we also have all of these muscles that I've been talking about that we need to produce speech. So this is a side view of the face, and the face is kind of cut in half. And so we're looking at the tongue here. These are the teeth. These would be the lips here. This is the larynx. These would be your jaw muscles here. And so there are a lot of muscles that are all interconnected here. And then also the tongue is a very complex set of muscles that need to be working all together to correctly control speech. This again is another picture of that side view of the tongue. And then this is the view of the tongue that's kind of been cut in half. So looking at a frontal section of the tongue, and there's a bunch of different muscles in here. So the brain needs to think about all of these things. It needs to think about what regions of the brain are active, what cranial nerves we're using, what nerves go from the brain into the muscle, and then all of these muscles and how they need to be coordinated during speech. So it's a really brief overview of how the brain controls the muscles that we use to talk. And so let's talk a little bit about how speech is affected by ALS then. So as I'm sure many of you know, ALS results in the progressive loss of control of all of the body's muscles. So over here, we see the affected nerve cell. So it's the affected nerve coming from the brain, which is innervating or supplying to this muscle here. And so if the nerve cell is affected, then the muscle is going to have trouble contracting. And so we see this in the spinal muscles, so in the muscles of the legs and the arms, but we also see this in the bulbar muscles, so in those muscles of the head and neck. And so these muscles are really important for speech and swallowing, and so we see these impairments in ALS. And I'm sure many of you have heard these terms, but they're called dysarthria. So dysarthria is a problem with the motor execution. So it's a problem with the signal coming from the brain and going into the muscles to be able to produce speech. And then dysphagia, which is the muscles that are important for swallowing. And so most people with ALS will experience these challenges at some point over the course of their disease. And I'm sure many of you can speak to this much more than I can, but obviously these greatly affect quality of life, having an impairment in the ability to talk and the ability to eat. So because I'm sure some of you have heard that ALS affects both upper and lower motor neurons. So the upper motor neurons are the neurons that are in the brain, and then the lower motor neurons are the neurons that are coming out of the brain and into the muscles. There are a range of symptoms that can be exhibited by people with ALS. So when we have someone who has lower motor neuron damage, so that's the muscles from the brain into the muscles, we see things like spasticity, so difficult muscles that are really difficult to move or too hard, they're really hard to move away from where their resting state. So they get really rigid and hard to move. And then, those are upper motor neurons. I'm so sorry, upper motor neuron findings. And then lower motor neuron findings, so the brain, the muscles or the nerves that are coming from the brain down into the muscles, we see weakness and we see muscle that is wasting, right? So we see kind of the opposite as we see in these upper motor neurons. So when we get upper motor and lower motor neuron difficulties together, it's really hard to tell, is it an upper motor neuron problem or a lower motor neuron problem? And I think that that's part of the challenge of diagnosing ALS, because for a diagnosis of ALS, you need to have both upper and lower motor neuron disease. And when someone is showing weakness, it's hard to know sometimes, is that because the muscle's having trouble moving from spasticity, or is it because it's weak? So lots of different symptoms that can be seen. And speech onset, or the onset of speech difficulties in ALS, is really highly variable. People look really different. Speech looks very different in individuals. And there's a really really variable progression across individuals. So we don't have a lot of great information about how speech declines, who's going to decline in what way, for example. So this loss in neuromuscular control leads to difficulty moving the lips, jaw, and tongue. And it results in characteristics of the speech that we like to call imprecise articulation. So kind of that slurred speech. I think a lot of other professionals that you probably meet will use that terminology. It also results in a slow rate of speech, so talking very slowly. Hypernasality, so that's when a lot of air is coming out of your nose when it shouldn't be. And then monotone, monopitch, and monoloud. So that's kind of not able to change the pitch with which you're talking, not able to change the volume at which you're talking. And so everything just kind of sounds monotonous. So those are the primary characteristics that we see in ALS. And they often result in what we call reduced intelligibility or understandability. That's kind of another term that we could use for intelligibility. So how much can a listener understand of a speaker? So hopefully today I'm about 100% intelligible. That would be really, really great. But having any of these perceptual characteristics may decrease intelligibility, may make someone more challenging to understand. It may also result in reduced naturalness. So it may just make speech sound not so natural, a little bit odd maybe for what we would expect to hear. All right, so let's talk about how we measure speech. This is my favorite part. So we've talked about why measuring speech is challenging, but we also know that it's a really good measure. So there are a lot of good measures of speech that are sensitive to disease onset and sensitive to progression. And so being able to measure speech is really important for improving care for patients with ALS. And so speech is measured differently in the clinic, which this is probably a picture that many of you would be kind of familiar with, seeing what a clinic looks like. And maybe this is what you think of when you think of a research lab. So speech is measured very differently in these two areas, but this isn't really what our labs look like. This is a picture of what my advisor's lab looked like. I'll talk about it a little bit more in a few minutes, but this is just to give you a little preview. And this is another picture of a speech lab. So they don't look quite what you would expect a lab to look like. I think a lot of people haven't seen what a speech lab looks like. So just to give you a little idea there. All right, let's just go over some key terms before we talk about how we measure speech. And these were some that Jen mentioned earlier when she was talking about my research interests. So the first is perceptual. And this is our use of the senses. So it's the use of hearing and seeing to measure something. And so this includes intelligibility, which is what I was just talking about. It includes how understandable a speaker is to a listener. And so I'll talk a little bit more later about how we measure intelligibility, but basically it's a listener hearing what a speaker is saying, and that's how it's judged. So it's using our ears and using our eyes, which I'll talk about in a second. We're also interested in the acoustics, and this is the physical properties of speech. So it's, in basic terms, it's the sound wave. So we look at the sound waves that come out, and we have some special equipment that allows us to look at what the sound waves are doing. And I'll show you some more pictures in a little bit. Kinematics are the movement of the articulators. So how we can look at, say, the lips and how they move. And then neurophysiologic is how the brain is working to produce speech. We're going to focus on the first three here today. So perceptual, acoustic, and kinematic. These are the ones you'll see most frequently and are the ones that I've been most involved in. And so I really love them. So how do we measure speech in the clinic? Let's talk a little bit about that, and then we'll move and talk a little bit about how we measure speech in the lab. So in the clinic, we often get these perceptual characteristics and estimates of intelligibility. So for example, someone will do a cranial nerve exam or an oral mechanism exam. Those are what they're called. They pretty much mean the same thing, but that might involve having someone move their articulators in different ways. So you might stick your tongue out and wiggle it side to side. You might get asked to puff your cheeks like that, to purse your lips, move your eyebrows. And so that's looking, and I put an eye here because we use our eyes to see how all of these things are moving. And it's called sometimes a cranial nerve exam because we can tell by looking and by listening how those cranial nerves are working. So those nerves that go from the brain down into the muscle. And we're using our ears to listen to what things sound. So we might have someone hum, we might have someone say an ah to hear how the vocal folds are moving. So we use our senses a lot in the clinic to tell what's going on with speech. But there are some challenges to this. They may be not the most reliable measures because, of course, we're relying on a listener to say what they hear. So me from today might say something sounds a little bit differently than I would tomorrow, for example. We all are kind of prone to error, right? And to bias. So, for example, if you're really familiar with a speaker, that might change how you would rate them on different parameters. So in the clinic, we also use several speech tasks to think about speech. So we might use something called maximum phonation time, and that involves asking a patient to say ah for as long as they can. So ask them to take a deep breath and say ah until they run out of breath. And that gives us an idea of what's going on with the respiratory subsystem, so with the lungs, and also with the phonatory subsystem, because we use our vocal folds when we say ah. So it gives us some clues to what's going on in the body where we can't see it. We use something called diadochokinetic rates. It's a big term for something that's not so complicated. We ask patients to say a syllable. So I'll use the syllable ba. We ask them to say it as quickly and accurately as possible on one breath. And so it sounds something like ba 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 ba, and as fast as you can go. And we measure things like how long they're able to go, the rate at which they go. So how many syllables can they produce in a second? And that has been shown to be a really good measure of the articulators and how they're working. That's always a fun task. And then we might have patients read aloud sentences or passages out loud, and we can get different measures from that. So this, if someone, a clinician might give you a passage to read out loud, so like a paragraph, and then they might just rate intelligibility. So they might say, okay, I think this patient is about 80% intelligible to me. I can understand about 80% of what they're saying. That's how it's typically done in the clinic. Although some clinicians might use acoustics, so they might record what you're saying and be able to look at the waveforms. We do that a lot more in research because it's quite time consuming. So we'll talk about that a little bit more when we talk about in the research lab. And then we also use patient-reported outcomes. So the ALSFRS, and I'll talk about the communication item bank in a minute. But you're all probably very familiar with the ALSFRS, so I won't talk about this too much, but I do just want to note that this only gives us one question about speech, right? It only asks, how is your speech? So that's the only indication from this measure that a clinician would get about how a patient thinks about their speech. And actually, this is kind of a good, to bring back what I was talking about before, why it's important that when we're talking about speech, we're talking about the same thing. And so now you'll all be experts in, if someone asks you how your speech sounds, you can think about all of the things we've talked about. Do you think your speech sounds natural? Do you think it sounds slower than usual? Those types of things. We also use something called the Communicative Participation Item Bank, or the CPIB. This is a little bit newer, so it's possible a lot of you haven't seen it, but it's a questionnaire that asks about how someone is participating using their speech in everyday life. So this is there's a short form, so it's 10 questions. I've blown it up here to make it a little bit bigger. So it asks things like, how does your condition interfere with talking with people you know? And then you would answer, not at all, a little, quite a bit, or very much. And then it asks about different scenarios. So this next scenario is communicating when you need to say something quickly, or talking with people that you don't know. So this is a way that we get at that participation level of the model that I showed you earlier. So just because the articulators are working in one way, this gives us a good idea of how the patient feels about their speech. How does it impact their daily life? So I really like this scale. All right, so I want to give you a little bit of the data that has been collected by some researchers in my PhD advisors group. My PhD advisor is Dr. Jordan Green. I have a picture of him later, so I'll show him to you. But he has a lab at the MGH Institute of Health Professions, and it's called the Speech and Feeding Disorders Lab. And he has quite a big a lab team there. And so we've collected some really nice data. And I'm just going to talk about this really briefly, just to give you an idea of how the measures that I just talked about, how they're used. So this is Dr. Kristen Allison, and she's now an assistant professor at Northeastern University. And she did a study while she was in the lab looking at what patients think about their speech. And she used the ALSFRS. So that one question on the ALSFRS, what does that tell us about what patients think about their speech? She also talked about how clinicians listen and how they detect speech symptoms in patients with ALS. We also got some instrumentation measures of speech function, which I'll talk about a little bit later. And her main findings were that both patients with ALS and experienced clinicians had difficulty noting really small changes in speech. And that was really interesting to us because that might suggest that there are these really subtle changes that are going on in speech before we can even detect them with our ears. And that's exciting to know, because if we can figure out which measures are the best for measuring speech, then we can tell really early on that something is happening. There is a subset of individuals with ALS for whom speech is the first symptom that they might have. And if we can detect that earlier than we currently can, that could be a really great thing for early intervention, getting in there really early. And she did find that there were some of these instrumentation-based measures that detected speech changes early. And so I'm not going to talk too much about that, except these are all the measures that they used. This purple line here is the clinician severity rating. And for a measure to be really good, we want it to be kind of moving up into this corner here. And all of these other measures are more instrumentation-based measures that we would use in research. So they all did a better job of telling us that someone had speech symptoms early on than did the clinicians' ratings. So it's like some exciting work. Another study I'll just talk about is a study that I just finished and submitted for publication. And we looked at how SLPs rate speech severity. So it's pretty common for clinicians to say, oh, their speech sounds normal. It sounds mildly impaired, moderately impaired. But I asked the question, how accurate are these ratings? That was something I was really interested in. We also looked at these other measures to answer questions about, are there measures that are better than clinician speech ratings, for example. And our main findings were that SLP's ratings were really reliable and really valid. And that was super exciting for me to see that clinicians are actually doing an excellent job being able to rate the speech of individuals with ALS. And this also provided us with some definitions for classifying speech impairment. So what does it mean when we're saying that someone has a mild speech impairment? What does that tell us about their speech? And so again, won't go into this data very much, but these are along the bottom here are some categories. So normal, mild, moderate, severe, profound. And each of these measures here. Each of these plots is a new measure. And we found that clinicians' ratings really lined up with all of these more objective measures, all of these measurements that we took. And that was really, really exciting. All right, so how do we measure speech in the lab, and how is this different from how we measure it in the clinic? So we do still listen for perceptual characteristics. We're listening for how speech sounds. It's always the first thing that we do. And then we also take measurements of intelligibility. So instead of estimating intelligibility or saying this person sounds mildly impaired, for example, we're measuring it. And I'll talk in a second about how we do that. And we use very similar speech tasks to what I described before. So that maximum phonation time, the weird diadochokinetic rates, the ba, 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 ba. We have research participants read sentences or passages out loud. But in this case, instead of just listening, we use acoustics and kinematics. So we look at the speech signal as well as the movement of the articulators. And we also use the same patient-reported outcomes. These are the best patient-reported outcomes that we have. And so we use those in the lab to tell us what patients think about their speech. All right, so first let's talk about intelligibility. Intelligibility is something I'm really interested in. And so intelligibility, like I said, tells us how understandable a speaker is to a listener. And how we calculate that is we have someone say a sentence, we record it, we have someone listen back to that sentence and write down what they think the person said. And then we compare the target to what the target sentence to what the listener wrote down, and we get a percentage, basically. This is just an example of what that might look like. So we have a speech sample here, we have a listener listen to that, and then we have them write word for word what they hear, and we can calculate intelligibility. So this percent intelligible words. This is a very interesting concept to me because it's influenced by a bunch of different things. It's influenced by what you're having the patient read. It matters, are they reading a sentence? What does the sentence say? What kinds of words are in the sentence? It's also influenced by how the speaker sounds, obviously, and also influenced by the listener. So is the listener a clinician who hears people with speech impairments all day? Is it a family member of a patient with ALS who is very familiar with their speech? All of those things influence the measure of intelligibility. So there are a lot of interesting things to look at there. We also use acoustics a lot. And I just wanted to give you an example of what that looks like. So up here is what we call the waveform. And this is these are the sound waves. And we can look at them and measure them in a particular program. This is what we call it. So this is across time here, sorry. So this is someone speaking. And for example, this might be one word and then another word. And then these are little pauses in between and then more words. And then this is the same thing except shown in a different way. So this is what we call a spectrogram. And we can look at different pieces of the quality of the speech. I won't get into that too much, but just to give you an idea of what that looks like. And then this is kind of, I think, where it gets really exciting. This is looking at the kinematics of the speech. So looking at the movement of the articulators. And so something that we use is called motion capture. And this is, again, the picture of Dr. Green's lab that I showed you earlier. And what you can see here is these cameras along the wall here. We have 1, 2, 3, 4, 5, 6, 7 cameras. And then the patient would be sitting in front of those cameras. So looking at, this is a TV screen, we can present what the patient has to do. We can present instructions, for example, on that. And what we would do is place these little reflective markers on the participant's face. So here we have them on the jaw, we have some on the lips, you see one on the top, on the bottom, and in the corners, one on the nose, and then we have a few up here. And those reflective markers are picked up by the camera and by the cameras and in the 3D space. So we can then measure how these are looking. She also has on here, you see these other wires here, those are EMGs. I'm sure many of you are familiar with EMGs. These are just little stickers that we stick on and look at muscle activity. And then this is just an example. You can see the computer here and you see the patient or the participant in the other room, and she has these sensors on her face. and she's just talking, and we're able to collect that information on the computer. All right, the next technology that we use in the lab is called electromagnetic articulography. And it's similar to motion capture in that we're still looking at the movement of the articulators. But as you can see, and if we go back here, because we need reflective markers for motion capture, the camera needs to be picking up the reflection of those markers. So we can't see the tongue using these, right? We can't put markers on the tongue because you can't see the tongue during speech. So that wouldn't work. The camera wouldn't be able to see the tongue. And so to be able to see the tongue, we use electromagnetic articulography. We call it EMMA sometimes. So for this, we see all of these little sensors on her face in the similar positions to where the motion capture sensors were, one on her jaw, one on the lips. But now we can put them on the tongue. So she has one on the tongue here. In this picture, this is a rendering here. We can see 4 of these on the tongue. So you can put as many as you like. We just use a little bit of dental glue to stick the sensors to the tongue. Quite easy, totally painless. You need to get your tongue a little bit dry because it helps the glue to stick, but it's really, really quite easy. We have it done to us all the time. We practice on each other so we can get good at it. And then we have this machine here, the wave machine, and that sits beside the patient. So I would be sitting here and this machine would be here, and it's able to pick up the movement of each of these sensors. Let me give you now a little video of what that looks like. So to give you just an orientation to this line here that you see on the screen, that's the tongue. So we see 1, 2, 3, 4 sensors. They're kind of hard to see, but that's the tongue as collected using this equipment. And then we see these other little markers here. Those are the lips and the jaw, but the tongue is really what's interesting in this video. So let me play this for you. You'll hear someone talking and you'll see what the tongue is doing during that.
Well, he is nearly 93 years old, yet he still thinks as swiftly as ever. He dresses himself in an old black frock coat, usually several buttons missing. A long beard clings to his chin, giving those who observe him a pronounced feeling of the utmost respect. When he speaks, his voice quivers a bit.
So that is what the tongue looks like during speech. Those are the types of movements that it makes. And you can see that it makes a lot of movements, right? And we wouldn't be able to know that if we didn't have this type of technology to be able to see the tongue. And so from that signal, then we can get things like range of motion. So how much is the tongue moving? We get things like speed. How fast is the tongue moving? We can look at it over the course of a passage or in, just a few vowels, for example. So it really is a very powerful tool to be able to look at the articulators. All right, now I just want to show you a little bit of data on that we have on these. So this was a study that I completed during my dissertation. And what you can see here, I'm going to show you a little graph. And what you see here along this axis is intelligibility, so how understandable someone is. And then along this axis, you see speaking rate in words per minute. So how quickly is someone talking? So up here in this corner, we have healthy control speakers. So they're talking quite quickly. They're neurologically healthy. So they're talking quite quickly. They have really high intelligibility. You can understand them very well. Then we see the people we call pre-symptomatic ALS. So they don't have speech symptoms yet. And we can see they are very similar to these healthy controls. They have a high speaking rate, they're talking quickly, and they also have a high intelligibility. And then we see this group of speakers. So their speaking rate is getting slower and their intelligibility is declining. So they're getting harder to understand. And this is what we would expect in ALS. We see that as speaking rate declines, so does intelligibility. But we in our lab had found this group of speakers up here who were slowing down. So they have a reduced speaking rate, but they're still able to be understood. And we, around the lab, called them robust talkers. I don't have that here, but we called them robust because although that they had some speech impairment, they were still able to be understood. And that was really interesting to me. And so looking at the difference between these two groups was really of interest. And so I used some of the acoustic measures I talked about and some of the kinematic measures I talked about to look at what's different between these two groups. And I'm not going to go into this too much, except to say that, so this is the acoustics, so this is the spectrogram, and we're able to look at what we call formants, which I won't get into, except that this piece of the spectrogram here is related to tongue movement. And so we saw that this was reduced in the people who were challenging to understand. But in people who were easy to understand, that we still had lots of tongue movement in those people. And so that really contributed to the evidence base that the tongue is really important for being able to be understood, right? This is an example of what a kinematic waveform would look like. So for example, this is between the upper and the lower lip during ba, 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 ba. And we can see that their lips are opening and then closing and then opening and closing and opening and closing. So we can see that going on. I see a message from Jen here who asks, were the high speech or robust talkers in your dissertation people with more predominant upper motor neuron involvement with predominantly spastic dysarthria? It's a great question, Jen. That's kind of what we think. It's because we don't have great measures of spasticity or upper motor neuron involvement. We couldn't conclusively say that, but that was kind of our hypothesis, I think. It's a great question. And then this is another way we look at acoustics. So here we're looking at the speech signal again, and we're looking at the amount of pauses during the speech. So we see speech here, and then a pause, and speech here, and then another pause. And this is a really great measure of speech impairment and really easy to get because someone just has to talk, and then we look at the speech signal that comes out of it. And in some research from my advisor and the rest of their group, they found the percentage of pausing, so how much someone is pausing, is a really early marker of speech impairment. And it's really great because one, it happens quickly, we can see it, but two, because it's easy to obtain. Someone just has to speak, we record it, and then we look at it. So that's very exciting. We don't have to use any fancy equipment. These are two of my colleagues here, Dr. Pinyin Rong and Dr. Marzieh Eshki, and they used kinematics to look at speech. And so this is similar to the movement waveform I was showing you before, but this one I've highlighted here again is the upper and the lower lip moving. They're opening and closing and opening and closing. And so that's what they looked like. They looked at that and how that can give us information about if someone has speech impairment or not. I won't get into this actually, but just showing us there was a bunch of, they looked at a bunch of measures. So they looked at how fast those were moving, how slow they were moving, et cetera. And was that able to distinguish between people who had speech impairment and didn't have speech impairment. So that was a very cool study. All right, let's talk about how we treat speech in ALS. This is Dr. Emily Plowman. She's at the University of Florida, and this is Dr. Jordan Green, who was my PhD advisor. So he's in Boston at the MGH Institute. And so the bad news about treating speech in ALS is there really isn't a great evidence base for it. Not a lot of people have done this type of research, partly because of all of the challenges we've talked about before to measuring speech, and partly for some other reasons, which I'll get into in just 1 second. So Dr. Plowman has done some research looking at respiratory muscle strength training. So doing some breathing exercises that it involves more than breathing exercises, but that's basically what it is. And she's found that can improve swallowing function, but no work to date has looked at that and speech. And so we don't really know if that can help speech or not at this point. And another one of the reasons here that I point out is why not very many people do this work, is because this type of exercise may actually fatigue the speech motor system more than help it. So there hasn't been any evidence that trying to do some strengthening exercises help with speech. It may actually make it worse, although we don't have evidence for that either. And I like to give the caveat here that this is just my opinion, not based on a lot of research, but it seems like it's better to work harder at making the speech that you do use more understandable than trying to make the muscles stronger, for example. And I'll talk about how we make the speech you use more understandable in a second. There's limited evidence for prosthetic management. So for example, some people might use like what we call a palatal lift. So getting the velum to be higher up in the mouth to be able to close off the nasal passage. But in ALS, which is quickly progressing, there hasn't been a lot of evidence for that at this point. There are some early studies, very early drug studies, that show some promising results for their impact on speech. So Dr. Green has done a study looking at Nuedexta, which maybe some of you are taking, which has been used to treat pseudobulbar affect. And some patients who were taking Nuedexta just anecdotally noted that they thought that their speech was getting better. And so Dr. Green and a group of neurologists and speech pathologists did a study looking at that. And there were some small improvements in speech, which was exciting to see. So again, very early studies, but they are ongoing. And there's certainly a lot of drug studies, which I'm sure you're all very familiar with. And some of them do include speech outcomes and looking at which ones actually might help with speech. So some strategies for improving speech and communication then in ALS. There's a strong consensus of expert opinion that behavioral strategies, which I'll talk about all of these in one second, are useful in ALS. So that's exciting. So for speech, some of the things that are in the literature that people have recommended, first is shortening the length of the sentences that you use. So again, Kristen Allison, who I talked about earlier, did a study looking at the impact of sentence length on how understandable someone was. And shorter sentences were easier to understand for most people. And so making whatever you need to say in a fewer number of words, at least at a time, maybe pausing a little bit more is helpful. And I say focusing on what we call clear speech. And so clear speech is really over articulating. So making everything that you say big, using a big mouth, really over articulating your speech, speaking like you're talking to someone who has a hearing impairment, for example. And there's not a lot of great evidence for this in ALS, but in other types of dysarthria, it's been shown that just using slow speech, so just slowing your rate of speech, isn't all that helpful, actually, which is not super intuitive. That's not what we would expect. So a lot of people, and historically, what's been told to people who have speech impairments is just to slow down. But in more recent work, that's been shown to not quite help as much. But slowing down a little bit and over enunciating have been shown to be really helpful in other types of dysarthria. Providing context for what you're saying. So if you're going to talk about a book, all of a sudden, say that that's what you want to talk about, and starting the conversation with, I'm talking about this. Or moving to a room with that item in it, for example. If there's some way to provide context, that's really helpful for your listener to have an idea of what you're wanting to talk about next. These ones seem pretty elementary maybe, but I think are sometimes the most helpful. So reducing the amount of distractions. So if the TV is on, and someone's trying to talk to you, it's harder to understand them, right? If you don't have good lighting, if you can't really see them, if you're sitting beside them, you might want to sit across from them, for example. All of those things help with intelligibility more than I think we even realize. I know that when I'm, say, in non-COVID times in a busy place, and there's lots of noise going on around, that I look at someone's lips automatically, right? I'm trying to look for other cues because it's hard to hear them. And so how can we make those cues more salient to our listeners, I think? And actually another good example of this, I'm sure you've all experienced, is wearing a mask and how much that impacts intelligibility. So if there are ways to give other cues, that's really helpful. And then I do, although this talk was more about speech and not about augmentative communication, this is kind of where we are with the research right now, is that this is the most important thing to be thinking about in terms of communication. So some alternative means, and there's a really interesting study in 2015 looking at participants with dysarthria or with ALS actually, and looking at their quality of life and how much it improved when they looked into AAC early on. And so obviously this is a really challenging topic to talk about, especially when your speech might be fine still. But as early as a patient is ready to start talking about it, the better. There are certain things like voice banking. So saying a bunch of sentences and then a computer can make a voice for you that sounds like you. And how nice that is when the voice actually sounds like you and it's before you have severe impairments, for example. And so I think as early as you're ready to start talking about augmentative or alternative communication is really important. And good news about treatment is that there are many advances coming. There is a lot of work going on in this area and in the Boston area in particular, actually. So there's a lot of work going on with using smartphone apps to measure speech, so to collect speech samples and measure it in daily life, and then improved AAC. And I want to show you a picture of a video of what this looks like. So this is what we call the silent speech interface. And this guy right here is using Emma, so those little sensors that we place on the jaw and the tongue and the lips. And he's going to say something he's going to mouth words. And then the computer is going to talk for him. So the computer is picking up the movement of the articulators and it's predicting what he's going to say. So hopefully you can hear this, but let's try it.
Hi, DJ, how are you?
I am fine.
So he's mouthing words.
How are you doing?
And then the computer recognized it and talked for him.
I use a silent speech interface to talk.
That's cool.
Do you understand me?
Oh, yes.
That's good.
So that's pretty cool. I hope you guys got that. It's still very, very early on. And the idea is that this computer program would be able to recognize very small movements of the mouth, even if they weren't like speech movements, even if it was just an opening of the mouth, that you could program the computer to say, this is what that person is trying to say with that movement of their mouth. And so that's some really exciting work that's going on. And then I wonder if any of you have heard of this. This is the Google Euphonia project. And I actually just want to take a minute to show you this video because it's very, very cool. So let me open this and I'm going to stop sharing for 1 second and then start sharing again here. Okay.
Google has very good general speech recognition, but if you do not sound as most of people, it will not understand you.
So sorry, I should have said this before too. So he's talking and his phone is writing down what he's saying. And typical speech recognition like this has difficulty with people who have speech impairments because it's not designed for them. It's designed for healthy, neurologically healthy control speakers, right? And so it just doesn't know what to do with speech that doesn't sound like that. But as you can see here, it's doing not a great job, but you'll see in a second that there is, this is what they're working on, is trying to make this work better.
No one's ever collected large data sets of people whose speech is hard for others to understand.
People who have multiple sclerosis, for GF, who had stroke, who stutter.
They're not used in training the speech recognition models. I mean, the game is to record things.
What's the temperature today?
And then have it recognize things that you say that aren't in the training set. Dimitri recorded 15,000 phrases. It wasn't obvious that this was going to work. He just sat there and he kept recording.
We need to make all voice interactive devices be able to understand any person who speaks to them.
You can see that it's possible to make a speech recognizer to work for Dimitri. It should be possible to make it work for many people, even people who can't speak because they've lost the ability to speak. The work that Shenxing has done on, voice utterances, from sounds alone, you can communicate. But there might be other ways of communicating.
Most people with ALS end up using an on-screen keyboard and having to type each individual letter with their eyes. For me, communicating is slow.
Steve might crack a joke and it's related to something that happened, a few minutes ago. The idea is to create a tool so that Steve can train machine learning models himself to understand his facial expressions. To be able to laugh, to be able to cheer, to be able to boo. Things that seem maybe superfluous, but actually are so core to being human.
I still think this is only the tip of the iceberg. We're not even scratching the surface yet of what is possible. If we can get speech recognizers to work with small numbers of people, we'll learn lessons which we can then combine to build something that really works for everyone.
To understand and be understood, that's absolutely unbelievable.
I love that video. Oops. Sorry. There we go. So there's lots of exciting research going on. And actually, if you are interested in that project, if you look up Google Euphonia, it will come up, and they're collecting data of people with speech impairments, and it's going on. There's researchers in Boston working on it, it's very cool. So all of this to say is that speech is very difficult to measure, but it's also very important. And so we really need high quality evidence-based measures of speech and improve scales of how patients feel about their speech, because that's what's most important is how do you feel about how you're able to use your speech. And we really need to do more on managing speech in ALS, because there really hasn't been a lot that's been done. Can we slow the progression of speech decline? Can we allow patients to maintain the ability to speak for longer? And how can we better support individuals with ALS in communicating as long as they possibly can? So more research in these areas is really, really critical. And with that, I'll just give a quick plug for my PhD advisors lab in Boston there. They're looking at validating an assessment tool, and it's done totally remotely, which is really neat. That wasn't the plan originally, but because of COVID, it got moved online. And so actually that makes it really easy to participate. All it involves is using the same, or doing similar tasks to what I talked about earlier. So making some facial expressions, saying some words, reading some sentences, answering some questionnaires. And it's done remotely with 2 speech language pathologists. And so anyways, if you have any interest in that at all, there's an email address here. They're all wonderful people. I have a picture of them here, which I'll show you. And just want to help people. And so thank you all so much for having me. And I'd love to answer any questions that you have about anything to do with speech.
Thank you so much, Kaila. That was fabulous. It was nice for me, at least, to geek out a little bit. It's been a while since I've really been in the research realm. Interesting is that Dr. Jordan Green, who was Kaila's PhD advisor, was my swallowing disorders instructor at the University of Wisconsin-Madison, and I'm not going to admit how many years ago that was, but it was very early on in his career that he taught me when I was training to be a speech pathologist. So it's kind of a small world in the ALS community. We all sort of know each other in the research community related to speech pathology. One of Dr. Green's collaborators, Dr. Yana Yunisova, she's at the University of Toronto. She was in the year ahead of me at the University of Wisconsin-Madison. So, and she is a prominent ALS speech scientist that collaborates a lot with Dr. Green as well. And you saw Dr. Emily Plowman, who was doing the research on respiratory muscle strength training. She was my PhD advisor at the University of Florida. So it's all a very small and close-knit group of scientists. So Kaila, thank you for presenting your work and kind of sharing the complexities of what speech is and how challenging it actually is to scientifically measure it and tease it apart from cognition and tease it apart from language, and then having to deal with all the different subsystems and all the different muscle groups. It's exciting. I had a question for you. You
Sure.
mentioned the WAVE device, which is where Kaila showed everybody how they use dental adhesives to put little sensors along the tongue. And you could measure the tongue movements. Actually, you showed it in 2D, but it's capable of doing it in 3 dimensions.
It definitely is.
So I, at one point, toured Dr. June Wang's lab down at the University of Texas at Dallas, right? Dallas.
He's at Austin now, but yes, he was in
now. Okay.
Yeah. Mm-hmm.
So I toured his lab and was able to actually see that as well there. How many research groups have something like that, where they're able to measure tongue movement in 3 dimensions relative to other movements in the face?
It's a great question. Not a lot. There really isn't a lot. My guess would be, less than 20 in the United States, probably. There's not many.
Thought, to be honest.
Yeah, there may even be fewer than that. It's always funny to me because we talk about the companies who make these machines, and there's a dozen people who do that work. I also do know that there are ones sitting in a dusty closet somewhere that I know that the University of Buffalo has one actually that no one's using. Mm-hmm. So I'm wondering if I can pull it out sometime, but
dust it off.
Yeah. But it requires so much expertise and so much time and learning. And so I think, the reason why.
Oh, the analysis is complicated. It's not a simple thing.
Mm-hmm.
Thank you very much for sharing all that.